It's truly a pleasure and honor to be this year's Rosenthal Lecturer, especially this is the 50th anniversary of critical care at Stanford. And I truly am honored. And because of this being the 50th, I chose not to talk about research or clinical problems we might do at Grand Rounds, but instead talk about critical care medicine, and particularly the past, the present, and the future. And I'll explain why in a couple of minutes. First, think for a minute, what's the first thing you think about when you hear the word 1975? If you happen to, 2 decades ago, been into pop music, you might think about the British band, the 1975. If this year you're into pop music, you might think about the song, not the 1975, which was by Knox. But we're not going to talk about that. We're going to talk about 1975, but for a minute, we continue the theme of music. In 1975, the top-selling song, Love Will Keep Us Together by Captain Neal, unknown, I'm sure, by all of the residents who are here, because they were not yet even born. The top-selling album, Wish You Were Here by Pink Floyd, some of the ones who are older here will certainly remember. And the album, which really was the important release of that year, Born to Run by Bruce Springsteen, who is still having a career in music. In politics, the president was Gerald Ford, having had Richard Nixon resign the year previously as a result of the Watergate scandal. And on the other side is the vice president. It's not Stephen Colbert, but looks just like him, but is Nelson Rockefeller. This was the year of the fall of Saigon, which was the end of the Vietnam War. And one of the themes is that events which happened long ago are still having a significant impact on how we approach things today. Gates and Allen began Microsoft. People were into mood rings and Rubik's Cubes at that time. In terms of films, One Flew Over the Cuckoo's Nest, for the first time in 4 decades, swept all of the major Academy Awards. That is Jack Nicholson, who looks nothing like he does today. Jaws kept a lot of people out of the ocean for a long period of time. And whatever your age is, you may well remember the Rocky Horror Picture Show, which came out 50 years ago. So a lot happened during that time. And one of the things which happened is, of course, the start of really critical care at Stanford, and began with the recruitment of Mike Rosenthal, who at that time had been at Bethesda Naval Hospital. He was recruited here as a multidisciplinary recruitment jointly by the Departments of Medicine, Anesthesiology, and Surgery to create a multidisciplinary unit. At that time, the unit focused on respiratory problems, was small, but rapidly grew into the units we have here at Stanford today. He has had a very storied career. He was medical director of the ICU and the intermediate ICUs for 22 years. He was director and eventually president of the American Board of Anesthesiology, on the board of directors, and subsequently president and chair of the board for the Foundation of Anesthesia Education and Research. He won 5 major teaching awards from the medical students, which at that time was unprecedented, and had multiple achievement awards. I would note particularly the Lifetime Achievement Award from the Society of Critical Care Anesthesiologists, and a Leffingwell Lecturer chosen by the California Society of Anesthesiologists. Dr. Rosenthal was an absolutely incredible teacher, as many of the people here know. He loved to teach at the bedside. He also loved to give lectures, particularly on physiology. As part of teaching, he recruited fellows. Starting from when he came that year, he had a fellow, and a fellow basically every year at that time. I was number 7. Many of these people have had long, storied careers at Stanford and elsewhere. As the ICU has grown, we've gone from 1 fellow a year to 32 fellows a year. Our most recent fellow right now, number 402, all due to Dr. Rosenthal. And among the fellows, he trained a whole long list of people here who have really helped shape the future of critical care from back then to what we have now in terms of running ICUs. Many of these people have become chairs of departments. They are markedly advanced research in critical care, large amounts of funding, and also created new ways of doing critical care. We're doing the Rosenthal Lecture here. It's an endowed lectureship. This is the 20th year of it. The speakers are chosen from national and international leaderships in critical care and medicine. And the topics have been really interested and varied over time. And that's part of what's leading me to what we're going to talk about. In 1905, as many of you know, Einstein had what's called the miracle year, annus mirabilis, publishing 4 papers that really revolutionized physics. In many ways, this being the 50th year celebration, Dr. Lorenzo in particular has organized a set of speakers throughout this year that are leaders in critical care and on topics of that. And what I'm going to do today is sort of try to summarize some of what was covered during that year, as well as a lot of my own comments. The year began with last year's Rosenthal lecturer, Norm Risk. Dr. Risk succeeded Mike Rosenthal as the ICU director. He did that for 23 years, and during a significant amount of that time had 2 other very critical positions: Senior Associate Dean for Clinical Affairs from the medical school and Chief Medical Officer for the hospital. And similar to Dr. Rosenthal, he received a large number of awards for teaching and critical care. And he sort of talked about where we've been and where critical care is going. I'll cover that topic, but I think with very, very different thoughts about some of it. So let's start with the past. One of the people who lectured this year, Hannah Wunsch, well-known researcher and critical care physician, who talked about polio in particular and how it influenced the way critical care developed. In the early 1950s, polio was a really major epidemic. I can really only compare it to what we went through with the COVID pandemic. In the United States in that year, over 50,000 cases, more than 20,000 cases of paralysis, particularly kids and young adults, and over 3,000 deaths. Globally, we had over 500,000 cases of paralysis and or death. And Dr. Wunsch focused on the epidemic in Copenhagen, which in that city had an impact very, very similar again to COVID. And you'll see how rapidly suddenly cases peaked at that period of time. Polio ended up being treated in patients with respiratory failure with iron lungs, and ICUs filled up with negative pressure iron lung ventilation. This was coming from, again, the Copenhagen, not a huge hospital, starting to get 10 to 12 cases a day of severe respiratory failure. Mortality incredibly high once patients develop respiratory failure. What really changed that and helped create as critical care as we know it was a physician there, Dr. Ibsen, who decided that negative pressure through an iron lung was not being very effective in many of those patients, and had the idea of taking what was only used in the operating room, tracheostomy and positive pressure ventilation, and moving that into the ICU. They didn't really have ventilators at that point in time. They had medical students 24/7 ventilating this large number of patients called, now here you see, student ventilators. And the results were dramatic. By the next year, Dr. Ibsen had completely changed the whole way ICUs existed. They were dedicated places. They had 24/7 staffing with specialized nurses. They did frequent vital signs and monitoring. They had to create blood gas analysis for these patients because there was no blood gas analyzers at that point in time, using positive pressure mechanical ventilation, not just lungs, but multiple organ support and resuscitation, and a diverse range of patient problems. And that really is the origin of modern day ICU. Legacy of polio was large. Ventilators, blood gases, respiratory physiology, ICU settings were standard, but also many of the other things we deal with here and in society. And then the long-term sequelae of viruses, we still nowadays are struggling with patients with post-polio syndrome. And I think we'll struggle with long COVID for several decades after this. Getting back to what was life like in the ICU in 1975, the really only ventilator we had was the MA1 ventilator. It was initially developed in 1967. It could only do constant flow volume ventilation, and the only modes were assist, control, and assist control. There was no SIMV. There was no PEEP. It made weaning patients extremely difficult, very, very different, obviously, than the wide array of ventilators we subsequently have developed. In 1975, the focus was really on physiology, hemodynamic physiology. Concepts, particularly of systemic vascular resistance, were really new to critical care. Before that, really ICUs focused only on blood pressure. I remember coming here and learning a completely different set of physiology from Dr. Rosenthal than what I had learned in medical school about caring for these patients. It was also the start of understanding right ventricular failure, which now has become a major problem in critical care. Respiratory physiology, same sort of concepts, we just didn't have them very well developed at that point, renal physiology, et cetera. So the start really of modern critical care in terms of physiology was development of the pulmonary artery catheter. It was developed in 1970 by Swan and Gantz. The initial one here only had a single lumen for administering anything through it, not the triple lumen plus balloon port that we have nowadays, but you see the classic picture of the waveforms as you direct it from the venous system through the right atrium, right ventricle, and into the pulmonary artery, and eventually wedging the catheter. A year later, 1971, was when they first had thermodilution added to it, and it was really used primarily in cardiology, not in medical ICU for a long period of time. Swan-Ganz catheter has an interesting history in terms of, I'd say, rise and fall of use. Again, developed in 1970. First usages were really 1975 when I was at the University of Chicago in 1975. I was part of inserting the first time they used a pulmonary artery catheter in the ICU. And it only took about a decade until the pulmonary artery catheter was used in over 40% of ICU patients, really dramatic expansion. And in 1993, Connors reported that pulmonary artery catheters were great because they provided better assessments than physical examination, et cetera. And those assessments changed the treatment of a large majority of patients. So that was the rise. The fall came pretty quickly. 3 years later, Connors reported that pulmonary artery catheters increased mortality in data. And that was followed by multiple randomized controlled trials, all of which suggested no benefit and even harm from the pulmonary artery catheter. Although many people nowadays question whether that was a problem with the pulmonary artery catheter, or basically people using them actually were not adequately trained in how to use them, misinterpreted a lot of the data, et cetera. And they disappeared from certainly medical ICU and were replaced by bedside echocardiography, non-invasive cardiac output. We'll talk about echo in a little bit, but not in medical ICU, but now in cardiovascular ICU, they've really made an incredible resurgence, and ICUs think of them as indispensable at this time. Possibly, it's a turn your phones off. And a lot of that was the development, which Stanford was a major part of the continuous cardiac output pulmonary artery catheters. So we actually were truly following a cardiac output. Physiology, which was really the focus of how we treated patients back in 1975, subsequently really declined dramatically. And what really drove that was the development of large randomized clinical trials, using those for systematic reviews, and the concept of evidence-based medicine, which was defined by Sackett, one of the founders of it, as the continuous, explicit, and judicious use of current best evidence, making decisions about the care of individual patients, which was hard to argue with. And ICU rounds shifted very much from talking about physiology to talking about studies that had been published and how to follow them. And as you'll see in that pyramid of evidence, the systematic reviews and randomized controlled trials are listed at the very top. One of the reasons for this is that physiology didn't really match outcome very well. I'm going to give you a bunch of examples. Let me begin with from 1975 really until 2000, the concept of using high tidal volumes, at least what we consider today to be high, 10 to 12 mils per kilo body weight, sometimes the actual body weight, not just predicted body weight, were being used to prevent atelectasis in intubated patients. PEEP was often minimized to avoid high inspiratory pressures, which might cause barotrauma to the lung. On the other hand, some places, again, thinking about physiology, wanted the best oxygenation patients with ARDS and used incredibly high levels called super PEEP. And all of this was based on the belief that interventions that improve physiology, like better oxygenation, would result in improved outcome. That was clearly disproved by really the only study clearly demonstrating better treatment in patients with ARDS, which was the Odds Network study of lung protective strategy. Over here, you'll see the blue bar representing low tidal volume, 6 mils per kilo, and the orange being high tidal volume at up to 12 mils per kilo. On baseline, they're the same. Day 1, you'll see that the high tidal volume results in much better oxygenation. On day 3, much better oxygenation. Day 7, the two go back to being normal, which might suggest on a physiology basis, high tidal volume is good, except the data was just the reverse, that high tidal volumes resulted in basically a third more patients dying as a result of that, an absolute difference in mortality of 10%, a very large amount. High frequency oscillatory ventilation was in vogue for a short period of time. Again, physiology that keeps the lung open, but minimizes our peak inspiratory pressure. And we did know that it could be useful in neonatal respiratory distress syndrome, but studies such as this one showed no benefit and even a tendency towards worse outcome with it. Inhaled nitric oxide, lots of data showing that in patients with hypoxemia, inhaled nitric oxide significantly improves oxygenation, but 9 randomized controlled trials demonstrated no benefit of inhaled nitric oxide in ARDS, and in fact, a strong tendency towards more acute kidney injury and higher mortality. Moving away from respiratory physiology, antiarrhythmic drugs, large meta-analysis here showing that antiarrhythmic drugs, obviously being used to prevent arrhythmias, actually had no effect at all on whether people died in arrhythmic death. But the drugs themselves resulted in increased non-cardiac and overall mortality. Another issue of physiology, not necessarily predicting what we expect, is almost everyone in this audience has been taught that patients who have chronic hypertension are going to need to be kept at higher blood pressures in order to have adequate perfusion because they've shifted their auto-regulation curve. Now, multiple studies, including the 2 here, which were just published in last week's JAMA, demonstrate that both in the OR and in the ICU, no matter what their chronic hypertension was, there was no benefit to a MAP more than 65. If we turn to sepsis, one of the major problems in ICU, we understand the physiology very well. We have lots of interventions to change that physiology, but in fact, none of those have resulted in any benefit to patients, which is why we have no drugs approved for treatment of septic shock. So a whole long list of cases where physiology did not improve outcome. But at the same time, I think we began to recognize that evidence-based medicine, which resulted in a change in how we treated patients, was also not necessarily improving outcome either. And so we had 2 Rosenthal lecturers actually back-to-back. First, Jean-Louis Vincent, probably the leading European critical care physician, gave the lecture called Protocolized Care, Interest and Limitations, primarily limitations, that we can't simply use what we see in a group of patients for an individual patient. And the following year, Brian Kavanaugh, who trained at Stanford in critical care and then ended up being the chair of anesthesiology at University of Toronto, talked about how physiology can get you into trouble if you don't understand it. And I think we now recognize that the physiology we think we understand is often not correct. And when we don't understand it, that's when we run into trouble. So why might physiology approaches not work? One of them is physiology is really complex. Just talked about sepsis a minute ago. Sepsis, we have, a slew of mediators and things going on, focusing on one of them when multiple pathways are really determining the outcome is likely not to be successful. Many of those studies use surrogate endpoints, and surrogate endpoints may themselves not correlate really well with outcome. The interventions themselves can often come at a cost. Giving patients fluid may temporarily raise blood pressure, but then you have to deal with the fluid overload. Inotropic support may indeed end up harming the heart, causing ischemia, etc. So we have to not just think about the physiology, but the cost of it. And patients and diseases are very, very heterogeneous. The fact that something may work overall on average does not mean it will work in that particular patient. And last, the studies look at treatment at one point, but the outcome is dependent really on the entire course of the patient, and different phases of the disease may benefit at one point and be harmful at another. So I think it's not that we should abandon physiology, but we have to get better at understanding physiology overall and recognizing what the individual patient's physiology is. And we'll get to that a little later. So let's talk more about sort of where we are now and where we're going. As I mentioned, one of the things that really has changed how we manage patients is the use of bedside ultrasound POCUS. And one of the speakers this year was Sarah Nickervan, who was critical care and cardiac anesthesia at Stanford, and now is up at the University of Washington as vice chair of education. And Sarah talked about how things change over time with the great resistance there was to adopting the idea of non-cardiologists doing ultrasound. She emphasized initially development of transesophageal echo intraoperatively was done by anesthesiologists. Dennis Mangano actually had to basically tape a echo probe onto a gastroscope to start doing TE. Ultrasound became a standard for central line placement. And with time, what was the very limited, bulky, expensive technology became much easier for use. And now many of you are carrying around butterflies with you. There was great resistance to adopting this. And as the field evolved, that resistance disappeared. We learned more about what we could achieve with ultrasound and developed protocols for its use. And in last year, a Society of Critical Care Medicine came out with guidelines, and now we have certification in patients with critical care doing it, and the range of things, cardiac arrest, septic shock, respiratory failure, volume management, and cardiogenic shock are all recognized as not just options, but as standards for the use of POCUS. Another aspect of how things will transition over time, Erin Hennessy, well known to many of us, critical care physician, chief resident, trained at Stanford, faculty here, now professor and vice chair of education at the University of Virginia, talked about really a transformation, how we train people in critical care. Part of the reason for that need to change was that although the number of positions available for fellowship each year have been increasing, the number of people choosing critical care fellowships, at least from anesthesiology, has not been, and a third of positions go unfilled right now, which is clearly not attracting the people who we think should be going into critical care in the numbers that we want. And her comment was really that we have to train people differently. While they're medical students, we have to really get them interested and excited about critical care. When they're residents, we need to rapidly move them into a fellow level role rather than just continuing to do the same thing throughout residency. When they're fellows, we have to be moving them into being faculty members. And a lot of that had to do with how we educate them, particularly the use of milestones. And once they've achieved some level in critical care, they should advance onto more of a fellowship level role. And ultrasound is one of the things that really attracts people nowadays. As we interview resident applicants, I can tell you about half of them are really, really excited about going to anesthesia because of ultrasound. Ultrasound has just continued to further expand, and we need to make use of that as we try to recruit people here. And then finally, one of the things that, again, really excites people about critical care nowadays is the growth of extracorporeal life support, ECMO, and you see the rapid increase which has occurred over time in the number of patients on ECMO a year. And we'll get more to that. So as we look at the future, two quotes here from Yogi Berra. The first, the future ain't what it used to be. I think we need to recognize that if we're going to survive, we need to be changing what we're doing and not just simply continue to do the same thing that got us to where we are. And the other one, obviously, it's tough to make predictions, especially about the future. So everything I say from here on may turn out to be completely wrong. Okay, one question is really Stanford is the place where multidisciplinary critical care has really flourished. Will multidisciplinary critical care survive in the future? At least my assessment, we know that our patients have multiple medical problems, no matter where they're coming from in the ICU, that a multidisciplinary intensivist is probably the best person to deal with that range of problems. And on the other side, patients come to the ICU now for more and more in areas that have great specialization, neurocritical care being a great example. And we, at the same time, need people with that level of expertise who focus on that in their careers and may not have that broader range of critical care skills. Similarly, for nursing, we need increasingly nurses who have, again, that specialized experience, but also able to take care of whatever the patient has. So I think the future is going to be a model that really is nowadays, in many ways, a Stanford model, which is having intensivists who have a wide range of knowledge and experience with specialists who have that special ability. So, for example, in our medical ICU, the lung transplant patients are taken care of jointly on rounds between a pulmonary transplant attending and the ICU attending. Want to focus a bit on cardiovascular ICU because I think that's a very important part of the future of critical care. And for the anesthesiologists, and in fact, for many of the people who we're training, that is the jobs that they're going to find because that's the expanding area. Cardiovascular ICU is not what it was 20 years ago. The patients, they're sicker, they're older, they're more frail, they have complex both cardiac and non-cardiac morbidities. We're now starting to see patients with adult congenital heart disease. It is a population that needs one person who both has expertise in cardiac ICU and also has general critical care expertise. There's increasingly complex surgical procedures. We think that the ability to do TE has become essential in this cardiac ICU. And cardiovascular ICU has really changed. The role of mechanical circulatory support, ECMO, has become a major factor in the care of many of these patients. That began 6 years ago with the COVID-19 epidemic, where we had a large number of patients with severe respiratory failure who could not otherwise maintain adequate ventilation other than going on ECMO. We now have several studies strongly suggesting that ECMO in patients with severe ARDS results in improved survival, and the more recent development of emergency CPR, taking patients who have cardiac arrest, who don't have very rapid return of spontaneous circulation, and putting them on ECMO is now a standard strategy with good data, again, for improvements in outcome. And as you can see there on the bottom, that increase in patients on ECMO per year has dramatically increased. And we now have pretty good data for outcome. Outcome used to be terrible with ECMO for adult patients here. Over 160,000 patients so far have had ECMO. Those getting for pulmonary disease, survival of 60%. For cardiac issues, about 50%, and even ECPR, these patients who have arrested survival is 31%, dramatically higher than would otherwise be expected. I think we're going to have people, again, in cardiac ICU who really are specialists in cardiac ICU, and ECMO is part of that. We have not just ECMO, we have multiple different kinds of ECMO, VA, VV, VAV, VVA, VPA, et cetera. We have different ways of cannulating patients. We have to know how we can unload the left ventricle when it's failing on ECMO, and we have, again, a range of different options. We have management of different problems. We have different ways and choices of anticoagulation and intensity. We have altered pharmacokinetics, and we have ethical issues. For example, the patient who's not going to get off ECMO, what do we do with that patient? Being able to do this requires having lots of experience. The number of patients with the need for that is large, and it's hard to train every ICU physician here to be able to manage that. So I think we're going to see that really as a true specialty within here. Last, I think what's really going to change things is the promise of artificial intelligence for critical care medicine. It's the perfect setting for artificial intelligence, big data. Critical care, the patients are complex. They have multiple organ dysfunction, multiple comorbidities, rapid changes in clinical status. No patient is identical to another patient anymore. We also have huge amounts of data that need to be analyzed, everything from simple vital signs to the specific waveforms, the ventilator parameters, medications, laboratory values, notes in the electronic health record, and even analyzing all of the images. There's just more than any human can ever analyze at the same time, plus all the omics data, genetics, proteomics, metabolomics, et cetera. And it needs AI to do that. In addition, what we think of as one disease, ARDS, we now recognize as many different phenotypes of that disease, each of which may require different treatment. Again, that's what AI is great at. Stanford, we pride ourselves now on precision medicine. AI is, in many ways, the solution to precision medicine, individualizing the treatment for the patient. AI is good in that it, when appropriately trained, is always providing expert-level skills, and we don't have enough expert-level intensivists for all the places that need it. It also, you don't have to be there 24/7, have that person there. It's there. And finally, we all get tired, we miss things, et cetera. AI is always vigilant. So I think that's really going to transform critical care. We're not remotely there yet, but note how quickly, these are just publications on AI and critical care medicine, how rapidly we're increasing all of the studies there. You can see we're doubling about every 2 years in the information we have. And a lot of that is because AI is not the same program it was several years ago. There's just a massive number of publications now. They demonstrate multiple uses in the ICU, prediction of different disease states, and basically everything you can talk about, including just, is the patient going to get worse? And patients in the ICU, they often get worse in many different ways, so that it helps to just talk about, is this patient on a downhill trajectory? Sepsis, we have devices that will predict sepsis up to 12 hours before it can be clinically recognized, for example. Also, it can predict prognosis, things like who's going to get better, who's going to die, who's going to be on the ventilator a long period of time, who will have to come back to the ICU, will they have functional outcome, et cetera. It's being used now, as opposed to having trained people in skills. It can do as good a job or a better job, for example, of interpreting echoes than a well-trained intensivist can. Same thing for echo, same thing for regional anesthesia. And it can interpret things. You already have seen, when we get a electrocardiogram, we get that little computer printout. AI can predict incredible things just from looking at the EKG. the ultrasound, TE, chest X-ray. We now have apps that are free and available that will read your chest X-rays for you, CT scans. We're using it now for EEG to tell us whether patients are having non-clinical seizures. And finally, helping us with clinical decision support. So whenever I talk about AI, I always like to ask ChatGPT what it has to say about it. That's after I've already figured out what I'm going to say. It says most of the same things. I asked, will AI transform critical care? And it says, yes. Artificial intelligence is already transforming and will continue to profoundly transform the practice of critical care medicine and lists early detection, prediction, decision support systems, workflow optimization, personalized medicine, and remote monitoring and virtual ICUs. And then it adds, in the future, we're likely to see AI co-pilots integrated into ICU monitors and EHRs, dynamic self-updating models that learn continuously from new data, which is important because it will deal with the reliability issue as we change our care for patients. And finally, human AI collaboration, where AI augments but doesn't replace critical care teams. Those of you who have played around with ChatGPT, you can ask it to do all kinds of amazing things. It's a large language model. And so I asked it to write an ode about AI and critical care. It's actually a very interesting one for space. This is one of the stanzas, and I just wanted to highlight those first three lines because I think it's interesting that it shows that together human and machine construct a new form of vigilance. The machine perceives with tireless accuracy. The clinician understands with purpose and conscience. So I want to sort of finish with a sort of quick summary of some things I learned from Dr. Rosenthal. One is get involved, and the quote, 80% of success is simply showing up. Figure out places that you can contribute to and join them. Advance knowledge. We published in the end 16 articles together, and I think it launched my career in research, and we had a lot of fun doing it. Find your passion, and success will follow you. I think people who are doing things that they're really passionate about are successful and enjoy it. Be a leader. Dr. Rosenthal was clearly a leader, and he inspired my path through leadership. When I first joined the ICU, I had done residency in internal medicine at Stanford, rotated through the ICU there. I then did the fellowship here and was a faculty member in critical care in the medicine department. I ended up going into anesthesiology because Dr. Rosenthal convinced me about the synergy of anesthesiology and critical care medicine. Always emphasized it's all about the patient. It's not about you. The patient is what always comes first. And along those lines, we just note this quote from Dr. Riccardi, a very famous intensivist, the Riccardi Award from the Society of Critical Care Anesthesiologists named after him. The ICU must be a place where humanity has high priority. And I think as we treat our patients and deal with their families, we always need to keep that in mind. I think importantly, Dr. Rosenthal had many difficult decisions to make. He always did the right thing. I like this quote from Lincoln: I would rather be a little nobody than to be evil somebody. Don't compromise, always do what's right. Be sure to have fun in the ICU. It can be hard work, but it can be very rewarding, and working as a team is really very much enjoyable. And if it's not fun, you're not doing it right. Pay it forward. People will train you, you train others, and remember to always, pay it forward to someone else. I want to just finish a personal thank you for Dr. Rosenthal. He was my teacher, mentor, sponsor, role model, and friend, and my success has really been as a result of Dr. Rosenthal, and I'm eternally grateful. And thank you for all of your attention here. Thank Dr. Rosenthal for all he has done for critical care. Mike, just stand up here. And happy to answer any questions.
Okay, I have two mics. So to avoid confusion, please raise your hand and I'll bring a mic to you and we'll go in order. Okay. All right. Starting us off.
What strategies should we use to help ensure our students and trainees continue to learn what they need to know while they use AI tools to help them make their decisions?
So I think one thing people would say is they have to learn how to use AI, which might sound trivial, but it's not. And they have to know basically the problems with AI, although we're quickly solving many of those, like hallucinations. But AI is primarily, although it sounds like it knows things, it doesn't know anything. It has no knowledge. It just is taking what's in the literature and sort of choosing words that it thinks describe it. So they have to recognize that although it may sound intelligent, it's not. You have to. It's one of the reasons that AI is not going to replace critical care physicians, doctors, etc., because it still is going to require people who are able to recognize whether AI is correct. But it's the same way that when genetics came along, we had to train medical students now to sort of understand how to use genetics information. Same thing will be true for AI. And again, it will make our lives in many ways much easier, but we're still going to have to be thinking through it, whether what's being said makes sense, and be sure that we're giving it the right information. We're still having trouble, for example, with if our studies have bias in them, what AI reports is going to have bias in it. And there's a lot to using it correctly.
So my question is exactly about that. Computer science says garbage in, garbage out. And that's one of the major criticisms of AI is there's a lot of bias in it. Like, for example, with critical care, pulse ox is not accurate on darker skin. And this is something that people who practice critical care sometimes don't even know. So are there any studies of AI errors? And do we know domains in critical care where AI is less reliable? Has that been looked at yet?
So the real problem with right so far with AI in critical care is it's getting data from so again, there's two types of AI. There's large language models, and then there's basically the machine learning, et cetera, that's analyzing huge amounts of data. Most of the critical care studies and applications are in that second category. It turns out that the AI analysis of what to do, what's going on, et cetera, deciding predictions, diagnoses, et cetera, are incredibly sensitive to the exact specific set of data it used to train on. And so if you right now train an AI system in the cardiac ICU, it will be completely useless when you go to the medical ICU. The patients are just completely different. If we're talking here, this is mainly an anesthesia area. If you train it on patients who are in an ambulatory surgery center and bring it to the Stanford operating rooms, it again will be just completely useless. And it turns out that very tiny changes make a huge difference. So if you take the Stanford ICU and the Brigham ICU, we think of them in some ways as being very similar, et cetera. It's going to likely be very different. And that's why what they're doing now is going to make a big difference, which is having not just that the system has been trained, but that it continues to train on the data it's getting so that it updates as things vary. But I think that's actually the biggest thing, that reliability right now has just not been that good. We think what's going on now is the training has been based upon the data from like a single institution, as Epic now is basically half of the country. now we have huge data sets that may allow the data to actually tell you what's different about different places and then be able to be applied to your specific one.
Hi. Oh, is that okay? Ron, this was an amazing overview of kind of where we've been and really appreciate you celebrating all of the sort of wonderful achievements that have happened in critical care. And then looking forward, I guess I have this question that we have, and you are predicting increased subspecialization within our practices. And where I appreciate the importance and value of that, I wonder, how do we balance that with the lost perspectives that we get from multidisciplinary involvement? And how do you think we can do both better going forward?
Yeah. I think we struggle a lot with that, and understand that Stanford is different from most other places which really don't have multidisciplinary ICU. To me, the model which works here very well is it's not going to be a single physician doing it. It's when you have people who have that real domain expertise, along with the internist who's been broadly trained, that you sort of get the best of both worlds. It's in some ways more challenging, but I think we see it again, medical ICU on lung transplant patients, on the bone marrow transplant patients. We see it very much in cardiac ICU, where the anesthesia, critical care, cardiovascular ICU trained people are working with the surgeons who also have their own areas of expertise related to the patient. It's more work for people because you're doubling, but I think it results in much better patient care, and that's the way the models, I hope, will progress over time.
Thanks, Ron. Couple of things. I don't have any questions.
Sit down.
And I sure as hell don't have the answers. My medical resident, my ICU fellow, my ICU attending from medicine, my anesthesia resident, my colleague in the ICU after your anesthesia residency, and then my boss for several years. And he treated me okay. One thing I would just say is, and I don't want to take too much time here, but one thing I just want to say is one of the roles I always said of my residents, my fellows, and my colleagues, my co-attendings in the ICU, is your primary job was to make me look good. And my God, you made me look good. So I appreciate everything you've done for me, and what you've done for the specialty, Ron. It goes so far beyond what I accomplished. It's unbelievable, and I love you, and I appreciate so much what you've done. Bravo to you.
Thank you.
And I'm to follow that?
Yes. It's everything.
Yeah.
Right?
Man. AI. So the AI model is obviously trained by available features. And so the question is, does critical care have all the available features that are needed? And this is an issue of algorithm optimization. To what extent is there a need for more biomarker discovery to provide more variance to those models? In other words, you look across the street at engineering right now, they're developing these amazing continuous precise biomarker sensors that can model continuously just about any immune inflammatory stress marker you want. How much room is there for discovery in that space to add additional features, or do you have the data that you need? You just need to optimize the algorithms.
No, there's huge interest in the use of particularly wearable technologies in the ICU. They give us data that's different than simply the vital signs we're getting. And partly using AI to create more AI data. So for example, assessing pain in the ICU, can be very challenging because patients may not be very responsive in terms of when you ask them for pain, they have altered mental status, et cetera. AI systems nowadays can actually assess pain by looking at the patient's face, for example, and in ways that we as people are not very able to do as an additional sort of measure. I think, AI, the more data you have, the better you are at analyzing. And people are looking through everything in the world. And I said a great example, which would not have been so obvious, is just looking at arterial waveforms to predict to predict almost anything you can name. The idea that the information we get applies only to the area that it comes from is clearly being proven wrong. So, you are trained as an engineer. Engineers believe that give me enough data and I can do anything. And I think that's where we're going to see AI go. And the more data, the more accurate it will be, even when it might be seemingly unrelated to what we're trying to analyze and predict.
Hey, Ron.
Charlie?
That was great perspective and looking towards the future. You talked about the transition from physiology to RCTs and how that revolutionized care. Where do you see clinical research in the ICU going, especially sort of for young faculty starting their careers in the space? Is it AI? Is it new types of trials? Is it big networks? Where do you see this going?
All of them. First of all, clinical trials nowadays are challenging as we normally think about clinical trials. If we wanted to study something in ARDS, we just don't have a large number of patients. The only ways of doing that is collaboratively, and some of that is clinical trial networks. Some of those end up to have to be, because those studies can be very expensive, industry sponsored trials for something that industry is interested in. There's a massive amount of data now and a lot of studies on simply using AI to analyze that data, resulting in meaningful publications. People can think about a critical part, I think, about doing research in critical care is having the right mentor. There's a huge range of potential studies, but someone has to guide people in what are good questions, both good in the sense of the answer will be meaningful, but also in the sense of that the study is feasible to do and actually get an answer out of it. So I think getting trained in clinical trial methodology is going to be very, very important for the people who want to do those studies. And that's particularly true. Stanford has great resources, for example, in that online, virtual, in person, et cetera, for people who want to do that. And, a large number of our ICU fellows are engaged in active research. I think also things, Angela Rogers has a very large biobanking system, and that can be analyzed and has been in multiple different ways to deal with understanding mechanisms, predicting outcomes, et cetera. So the more data when it starts off with, the more likely it is that you'll be able to have a good question and a good answer to it.
Thank you very much, Ron. That was amazing.
Yeah.
We have 4 raffle